Hello everyone, happy evening, a very good evening. Welcome to today's session, the YouTube live session where we are going to quickly review in 25 to 30 minutes or so on renal pathology, right? So before I proceed with the session, a quick nod whether the audio visual is good, guys. Hi. So I think the audio visual is good, guys. Can you please give a quick nod? I'm waiting for a nod from all of you so that we can start with the session. Thank you so much, Saundarya, for that quick nod. And how about the slides? Are you able to see the slides? The slides are not seen, that's what I'm seeing. Give me a moment, guys. I'll be back with the settings. Just give me a moment. Yes. Are the slides visible now? Are the slides visible now? That is what even I could see, only the wallpaper, nothing else. I think you can now see the slides, yes? Chalo, that's good now. So let's start with our today's session. So in the today evening session, the special class, we had cardiology discussion, predominantly infective endocarditis and myocardial infarction. I hope all of you have enjoyed that session, and that gives you an insight into what kind of questions we can expect in our exam. Renal pathology, I had given you a homework to revise this from the previous special class that we had on the app. If you have not done that, worry not, please do that after the session. Everything in detail has been covered. In this session, quickly we are going to revise like we would do one day before the exam, a quick revision of the renal pathology. Alright. So there are some flashcards, there are some MCQs. Alright. So let's start with it. Before that, guys, if you are confused what to study at this last moment, Unacademy Plus subscription can come to your rescue, and you can definitely try the new course that we have started, the last mile to crack NEET PG. Plus you have your daily free test series on Unacademy app, 20 questions, 20 minutes, the various times 8 p.m, 8:30 p.m, 9 p.m. Apart from that, 10 a.m. and 10 p.m. I personally conduct based on the daily targets. So you can attempt those tests as well. For attending the free classes, all you need to do is download the Unacademy app. To activate, just use the code Dr. Nikita Live. Alright, and whenever you are subscribing, again you can use the code Dr. Nikita Live. Based on whatever is your duration that you are targeting, you can take the subscription, and I'm sure that will be very fruitful. So this is the course that I was talking about, the last mile to crack NEET PG, started on 22nd February. So do not miss many sessions if you have not joined yet. 22nd को start हुआ है. By 27th March your all 19 subjects will be covered, and you have the best of the educators for each subject to complete your syllabus well in time, right? So let's start with our renal pathology. The first image, very important. This is an image from your reference book Robbins. Okay, so quickly we will see this image, then we'll see the flashcards, and we'll see some MCQs on renal pathology. All right. So in this image, number one, what do you see here? What is happening here? This is basically the epithelium. This is where you have the basement membrane. So on the epithelium side of the basement membrane, you have these humps, right? There are these humps on the subepithelial side. So number one that you see in this image are subepithelial humps. And in which condition we see this lumpy, bumpy appearance or the humps? We see in post-streptococcal glomerulonephritis, also called as acute proliferative glomerulonephritis. Proliferative because we see a lot of cells coming into the glomerulus. You have neutrophils, basically WBCs coming there. So remember, first is subepithelial humps. Second one, what do you see in number 2? What is this image showing? So again, it is on the epithelial side of the basement membrane. These are called as subepithelial, not humps, but deposits. These are subepithelial deposits or epimembranous deposits. Epimembranous deposits. In which condition we see this? In which condition we see this? So those are in between the epithelium, okay, not beneath the epithelium. Subepithelial humps nahi hai. These are deposits, epimembranous. As the term says, membranous. So these are seen in membranous nephropathy. These are seen in membranous nephropathy, a very common cause of nephrotic syndrome in adults. In children, it is your minimal change disease, right? The third one, what is the third, number 3 showing you? Now this is the basement membrane, the epithelium side. This is the endothelium side. Okay, this is where you have the endothelium. The endothelium is fenestrated. So these are subendothelial humps. Number 3 that you see here, they are towards the endothelium. So these are subendothelial deposits, which are seen in membranoproliferative. They are seen in membranoproliferative glomerulonephritis. How do we remember that? Endothelial, endo is O, all your O, membranoproliferative. Membranoproliferative, OO is subendothelial deposits. Alright. And here you have number 4, that means in the mesangium, these are your mesangial cells and this is your mesangial matrix. In the mesangium, which condition produces deposits? Mesangial. So when you write mesangial, it is A. Okay, it is A. So it is seen in IgA nephropathy. Similar to IgA nephropathy, your Hinault-Schönlein purpura. Remember these two causes of mesangial deposits. Very, very important. Okay. So this is basically what is your basement membrane. Basement membrane. You have the epithelial side. You have the endothelial side. Subepithelial humps, PSGN, subepithelial deposits, membranous, and then you have your membranoproliferative, which gives subendothelial deposits, okay, and mesangial in IgA. Now based on this, let us quickly revise, have some flashcards. So tell me, where do you see the subepithelial humps? The lumpy bumpy appearance. The lumpy bumpy appearance is seen in which condition? Subepithelial humps. Absolutely right. PSGN, also called as APGN, acute proliferative or post-streptococcal glomerulonephritis. Anti-streptolysin O, ASO positive, after throat infection, you get the symptoms, right? Where do you see basket weave appearance? In which condition do you see basket weave appearance? Basket weave appearance. Who weaves the basket? Out of all the renal conditions that you see here, one is based on the name of the person, that is very good, Alports. So basket weave appearance is seen in Alports. Okay, what do you see in Alports? Anterior lenticonus, you have SNHL and you have your renal manifestations. So the eye, the ear and the renal manifestations. Basket weave appearance, somewhere the basement membrane is thin, somewhere the basement membrane is thick, like you weave a basket. So remember, Alport is a person who weaves the basket. He is a basket weaver. You get basket weave appearance in Alports. IgA nephropathy deposits, where do you see the deposits? Subepithelial, subendothelial, intramembranous, mesangial. Where do you see? Where do you see the IgA nephropathy deposits? Very good. A is mesangial. A is mesangial. So you see mesangial deposits in IgA nephropathy. Mesangial deposits in IgA nephropathy. What is the history in IgA nephropathy? Very common in children. After sore throat, the patient gets hematuria after sore throat. And this is a recurrent thing which happens and it gets fine automatically. Okay. So recurrent hematuria after sore throat in a child, think of IgA nephropathy. Okay. Think of IgA nephropathy. After that, Tramtrack appearance. Where do you see Tramtrack appearance? Tramtrack appearance is seen in which condition in the kidney? Tramtrack appearance. Very good. That is your membranoproliferative. जैसे Tramtrack is your two words, made up of two words. The condition made up of two words in the kidney. Remember, membranoproliferative. Membranoproliferative has a Tramtrack appearance. Okay, it has a Tramtrack appearance. Linear immunofluorescence. Linear deposits on immunofluorescence. Which condition? Which condition shows linear immunofluorescence? So in your immunofluorescence, you can get granular deposits or you can get linear deposits. Granular deposits tell you it is an immune complex pathology, antigen antibody together. Linear is basically just antibody disease. There is an antibody. Very correct, guys. That is good Pastures syndrome. Absolutely right. Good Pastures. Because in good Pastures, you have anti-glomerular basement membrane antibodies. Okay. So remember that GP, good Pastures, has GB, that is glomerular basement ka antibodies. Glomerular basement ka antibodies. GB antibodies seen in good Pastures. Seen in good Pastures. What is the mnemonic to remember your good Pastures? 1, 2, 3, 4. That is, good Pastures is your what type of RPGN? In your RPGN, you have type 1, type 2, type 3. Type 1 is antibody wala. So it is type 1 RPGN. What is 2? What is 2? It is your type 2 hypersensitivity reaction, antibody dependent. 3 and 4 is your collagen which is affected. Collagen type 4 present in the basement membrane. Alpha 3 chain, that is called for A3 is the gene. That is your alpha 3 chain of collagen type 4 is affected, right? So you have called for A3. So remember type 1 RPGN, type 2 hypersensitivity reaction and call for A3. That is what is there. Okay. After that, membranoproliferative, we said that it has subendothelial deposits. Remember, membranoproliferative has subendothelial deposits. It shows your Tramtrack appearance. In your type 2 MPGN, type 2 MPGN, 2 is though, that shows your dense deposits. Okay, that shows your dense deposits, continuous dense deposits in the basement membrane, which gives a ribbon-like appearance. Very important, the key word in your exam, ribbon-like appearance, continuous, that is your membranoproliferative type 2 dense deposits. Okay, so membranoproliferative ho gaya. Okay, let us see some MCQs, then we'll see some images in renal pathology. So this is the question right in front of you. What do you think would be the answer to this question? 1, 2, 3, 4 submarine is for good Pastures. That is for good Pastures. Okay. What do you think is the answer to this? Very good. So Shivani has answered it rightly, the first. Okay. So look at the question. The question is, what is the classic histologic finding in this renal disease? You see the second last line, lengthy questions, last line, second last line. That is how we read. Serologic testing is positive for anti-glomerular basement membrane antibodies. That is GB antibodies are there. So what is the diagnosis? Good Pastures. So you have linear immunofluorescence. You have linear immunofluorescence. Very, very important. Image also can be asked. Where do you see lumpy bumpy immunofluorescence? Lumpy bumpy is your post-streptococcal, right? Very important again, spike and dome appearance. Where do you see the spike and dome appearance? Spike and dome appearance. Spike and dome appearance is seen in which condition? Spike and dome. Very good. That is seen in your membranous. That is seen in your membranous nephropathy. Remember, spike and dome is seen there. Subendothelial is your membranoproliferative. Membranoproliferative is your subendothelial. Tramtrack appearance is your MPGN again. Tramtrack is membranoproliferative. Alright. Let's see the next question now. Read the question and get to the answer. What do you think is the answer to this? What do you think is the answer to this? Yes. So a confusion between PSDN and IgA. What do you see here? A 5-year-old boy, hematuria. Mother said he has had a sore throat for the past 2 days. दो दिन से sore throat है और hematuria भी आ गया within 2 days. And he has had hematuria a few times in the past also. So this is recurrent hematuria concomitantly with a sore throat. जैसे ही sore throat हुआ, the child gets hematuria. And then the mother states that the urine returns to normal clear yellow color after a few days. So this is recurrent hematuria concomitant with a sore throat. It is happening recurrently. So this is your IgA nephropathy. Okay, this is your IgA nephropathy. Please remember that your minimal change disease, Dr. Alok, does not have hematuria. It's a nephrotic syndrome. Okay, nephritic are the ones which show you your hematuria. So this is IgA nephropathy. Okay, this is IgA nephropathy. For LPOT, they will give you history of anterior lenticonus, sensory neural hearing loss, that will be there. Okay. Good Pastures may, it affects the alveolar basement membrane also. So you will have hemoptysis along with hematuria. Hemoptysis or hematuria, dono hoga. Okay. Post-streptococcal, it comes a few days later after your sore throat and ASO positive rega. Not within 2 days, you'll get the hematuria. Alright. Next one. This is your next question here. Read the question. Again, a bit of lengthy question. To give you a practice of such lengthy questions, right? So what do you think? Absolutely right. So when you see that ASO titer, anti-DNase B titer are positive, you know that it is post-streptococcal glomerulonephritis. And the question is, what is the most likely mechanism? PSGN is basically your immune complex deposit hota hai. It is what type of RPGN can it progress to? It can progress to what type of RPGN? Type 1, type 2 or type 3? What type of RPGN is immune complex? First is only antibody. Second is antigen plus antibody. Third is posse-immune. So immune complex is your type 2 RPGN. Right? It is your type 2. ANCA positive vasculitis is what type of RPGN? ANCA positive. It is posse-immune. Type 3. It is your type 3 RPGN. You have vaginous granulomatosis and the other ANCA positive conditions. Okay. Antibody against glomerular basement membrane, that is your good Pastures syndrome. History of hemoptysis and hematuria, that is what you will see. ASO positive, PSGN, immune complex deposit, you have subepithelial humps. Okay, subepithelial humps. Let us see some images, only a few images, very, very important. What do you think is the image showing here? What appearance is it showing? Look at this part, very clearly seen. Look at this part. What appearance are we seeing here? What appearance are we seeing here? Very good, cotton shoes. That is your spike and dome pattern. Okay, you have the spike and dome pattern. So look at the spike, look at the domes. You see the spike and dome pattern. Where do we see the spike and dome pattern? Where do we see the spike and dome pattern? Membranous nephropathy, right? Membranous nephropathy, common cause of nephrotic in your adults. It shows what deposits? Epimembranous or subepithelial deposits, right? Epimembranous deposits. Membranous shows epimembranous deposits, okay? Next one, what do you think is the diagnosis here? What do you think is the diagnosis in this image? Very good. That is your dense deposit. Look at the dense deposit, the black color deposit throughout continuous manner may causing the thickening of the basement membrane, a ribbon-like appearance. So ribbon jaisa appearance, dense deposits continuous. Dense deposit is though, that is your type 2 MPGN. Okay, this is your type 2 MPGN, the ribbon-like appearance, dense deposits, right? Next one, what do you think is this image showing? What do you think is the diagnosis in this electron microscopy image? What is the diagnosis in this electron microscopy image? So some of you have got this right. Yes. This is your alpods, because look at the basement membrane. The basement membrane is thin here. Look at the thickness of the basement membrane here. The basement membrane is thick there. So somewhere it is thin, somewhere it is thick, like a basket weave appearance. Okay, जैसे हम basket देखिए कि उसमें ऐसे basket होता है, basket weave. So somewhere it will be thin, somewhere it will be thick, where the two are coinciding. So thinning and thickening, that is your basket weave appearance. Who weaves the basket? Alpod. Okay. And what is the gene affected? It is collagen type 4, call for A5. In alpods, it is call for A5. In good pastures, it is call for A3. In good pastures, it is call for A3. Both of them collagen type 4 because it is present in basement membrane. Floor has type 4 basement membrane. Alpod alpha 5 chain, good pastures alpha 3 chain. Okay, that is your alpod syndrome. Anterior lenticonus sensory neural hearing loss and the renal manifestations. That is what you will see. Okay, that is what you will see. What is this image showing? It is already being labeled. Look at these areas. Look at these areas. You see that they are appearing more pink. That is glomerulosclerosis and like nodules. So this is your nodular glomerulosclerosis of diabetes mellitus, which are called as KW lesions. The Kimmel-Steele-Wilson lesions. Very, very important and frequently asked. They can give you a question like, this is what you see in histopath. What is the associated finding, the lab finding that you will see? So diabetes patient, the lab finding that you will see is hyperglycemia. Okay, diabetes mein dikhta hai your KW lesion. Okay, so remember that diabetes mellitus shows your KW, M ka ulta, KW lesions, Kimmel-Steele-Wilson lesions. Okay, apart from that, the arrow is showing that the vessel also is showing hyaline arteriosclerosis, right? Hyaline arteriolosclerosis is also seen. This is your nodular glomerulosclerosis. Nodule जैसे pink दिख रहा है, that is your nodular glomerulosclerosis. Okay. Next one, what do you think is the diagnosis in this image? Which nephropathy is it? Is it PSGN? Is it membranous? Is it membranoproliferative? What is it? PSGN, membranous or membranoproliferative? What is this? Some of you say PSGN, some of you say MPGN, minimal, membranous. Okay, so I see a lot of confusion here, guys. So a quick points on how to identify the image. This is not PSGN. This is not your membranoproliferative. This is membranous. This is membranous. Okay. Now, how to identify this is PSGN. Remember the most important thing in your image, a lot of neutrophilic infiltrate will be seen. That is why proliferative. Okay, it is also called acute proliferative. You will see a lot of WBCs, you know, the neutrophils coming in. Membranoproliferative. It is membrano and proliferative. So you will see again increased cellularity, increased lobules in the glomerulus. Okay, Tramtrack कभी आपको इसमें इलेक्ट्रॉन माइक्रोस्कोपी में दिख सकता है, लाइट माइक्रोस्कोपी में लॉबुलेशंस बढ़ेंगे और आपकी सेल्युलैरिटी भी ज्यादा रहेगी. Membranous, remember it is your thickened membrane. That is what only you see. No increase in cellularity. There is no increase in cellularity. What do we see in this image? You just see the thickened membrane. We are seeing the thickened membrane which is there, a very thick membrane. That is the highlight of membranous nephropathy on light microscopy. So remember, thick membrane is membranous. There is no proliferation, so there is no increased cellularity. Okay, there is no increased cellularity. I've covered all of these images in your special class. I'll share the link in the comments so that you can go back and quickly revise that session as well. In the renal pathology, all the images also have been covered there. Okay, so a thickened membrane, a very thick membrane like this without increased cellularity, that is your membranous. Minimal change disease in your light microscopy, it is normal. Light microscopy normal hai. It is an electron microscopy where it can show effacement of the foot processes. That is what it shows, nothing else. Light microscopy में आपको ये thickening वगैरह कुछ नहीं दिखेगा. Okay. Minimal change disease is also called your lipoid or lipoid nephrosis. It is also called lipoid nephrosis. Alright. And then you have FSDs, focal segmental glomerulosclerosis. As the term says, focal segmental glomerulosclerosis. Again you will see glomerulosclerosis, pink areas. In few of the glomeruli, suppose if there are 4 glomeruli, 2 will show the glomerulosclerosis. Even in them, only a segment of glomerulus will show the sclerosis, not the entire glomerulus. So that is your focal. That means few number of glomeruli are affected. Segmental means a part of glomerulus is affected. FSGS, the most severe type, is your collapsing variety. Can be seen in patients of HIV. HIV patients, collapsing FSGS, that is what you should see. Okay. Then this is about a quick review of your renal pathology. As I told you, a lot of it I have covered more in detail with the table from Robbins. जो आपका Robbins में table है in renal pathology, glomerular pathologies, that has been covered in detail in the special class. Alright. So please watch that session as well to complement this session. This session would have been the most useful for the students who already did the homework, watching that special class and coming to the class. Alright. So every day 5 p.m. and 9 p.m. at least for this month, we are going to have your free live classes. This is going to be on the app and 9 p.m. is going to be on YouTube. We are going to discuss very high yield topics for your exam, and tomorrow in the 5 p.m. class, the homework that has been given to you is to watch the CD markers ka session which I have taken in the previous plus class, and to watch the hematology special class that is taken in the special class, that is the free class. Plus we will have throwback Thursday. It's a Thursday tomorrow, so some PYQs and some USMLE pattern clinical MCQs will be discussed. So that is the plan for 5 p.m. tomorrow. For 9 p.m. tomorrow, the plan is to discuss your subtypes of renal cell carcinoma. Okay, so what are the important one-liners that we should remember for renal cell carcinomas, the various types, what are the syndromes associated with renal cell carcinoma, the gene, the chromosome, the subtype of carcinoma, that we will see in the tomorrow's session at 9 p.m. Alright, so that is about the session. The YouTube sessions are going to be short like this, right? Because I know कि बहुत ज़्यादा हो जाता है. We have 1 hour 15 minute session on the app every day at 5 p.m. right? So that we are definitely going to have. And PDF of this lecture I'll share on the Telegram group. Whatever I discussed, I'll share on the Telegram group. Okay, you can grab the PDF from the group. All right. So that's for now, guys. That's for today. Let's meet again tomorrow at 5 p.m. And I hope you are not getting worried with the new pattern change in the exam. You have all the resources to practice. Do not get bogged down. Just have 1 hour, 1.5 hours every day to practice some clinical questions. That's it. Rest remains the same. Do what you have been doing up till now. Okay. So goodbye, guys. Goodbye. Take care. Keep studying, keep revising, and keep